The following podcast is part of a certified educational activity titled Preparing Your Practice for the New Era of Amyloid-Targeting Therapies in Alzheimer's Disease, Expert Insights on Key Evidence, Administrative and Clinical Considerations, and Best Practices for Individualized Patient-Centered Care. Access the entire activity and complete the post-test at peerview.com/NUR860. Downloadable slides and practice aids are also available.
Welcome to this case-based activity focused on practical considerations for integrating new disease-modifying therapies into clinical practice to optimize care for patients with early-stage Alzheimer's disease. My name is Sharon Shaw. I'm a clinical professor and chief of the Memory Disorders Division, associate vice chair of clinical research for the Department of Neurology and Neurological Sciences at Stanford University. With me is Dr. Steve Salloway, professor of neurology and psychiatry at the Alpert Medical School of Brown University in Providence, Rhode Island. Thanks for being with us. The relevant disclosures are both Dr. Salloway and myself have been principal investigators or site principal investigators of the therapies that we're discussing today, including lecanemab, donanemab, aducanumab, and I've been a consultant for Eli Lilly as well. Our goals for today include developing comprehensive protocols to manage the novel administrative and clinical procedures associated with delivering amyloid-targeted therapies. We want to implement strategies for monitoring the safety and effectiveness of these amyloid-targeted therapies in individuals with early symptomatic Alzheimer's disease. And finally, we encourage collaboration with members of the care team to ensure safe and seamless coordination of care for patients receiving these amyloid-targeted therapies. All right, for background, for these amyloid-targeted therapies, it's nice to know where we are today and how did we get to this position. So in June of 2021, aducanumab was the first therapy that received accelerated approval by the FDA for the treatment for early Alzheimer's disease. It was in January of 2023 that lecanemab received FDA accelerated approval for the treatment of early Alzheimer's disease. And then in July later that year, lecanemab received a full traditional FDA approval for treatment of early Alzheimer's disease. And then in January of this year, the manufacturer of aducanumab announced discontinuation of it. To get some background about lecanemab and why it got approved, the primary endpoint for functional independence of the CDR sum of boxes, known as the Clinical Dementia Rating Scale, sum of boxes, demonstrated in the patients, about 1,800 patients who were enrolled in the clinical trial after 18 months, compared to the placebo in orange, who got worse, the treatment group got less worse over time in a statistically significant way, essentially 27% slowing on the treatment group by 18 months. And what we really notice from these amyloid-targeted therapy is that it does what we think it does. It's really targeting amyloid. So as denoted by amyloid burden by PET scan, we can see in this graphic that in the placebo group, in the orange, there's a flat line. There's no change in the amyloid burden as denoted by PET. But in the treatment group, lecanemab in blue, we can see that there is reduction in that amyloid PET burden as noted by decline or less than 30 centiloids in that lecanemab treatment group at 18 months. So there really is a difference in a change, and this treatment is targeting amyloid. We also see that donanemab, another amyloid targeting therapy, also reached its primary endpoint and also found that there is less of a functional decline in that treatment group. As we see in the placebo group in orange, there's a decline in the CDR sum of boxes as well. And in the treatment group at 76 weeks, there's less of a decline, as denoted by 29% slowing of donanemab at 76 weeks. What we see in the donanemab group, it also recapitulates that we notice that the donanemab does target amyloid, and we see that in the treatment group, there's reduction in amyloid at 76 weeks, as expected. And what we're focusing on this webinar is really the safe drug administration and treatment monitoring when we administer these drugs for our patients. We're not focusing on the patient selection, though this is really important and is part of another part of our series. What we really want to do today is think about practical tips for implementing these amyloid targeting therapies in clinical practice. Every site is different, but we really need to be conscientious of our site-specific protocols that are required to develop and facilitate the rollout of these amyloid targeting therapies. Now, every institution will have their own unique barriers and challenges to address, but we really want to think about what protocols can help facilitate for your site. What's important is to make sure that patients have the biomarker testing to confirm that they are appropriate for this treatment. Those biomarkers can include cerebrospinal fluid testing or amyloid PET scan. So confirming that your site works with other centers that can interpret and address the volume of patients that you're referring for these tests. We want to be proactive about patient safety. So one of those requirements is to determine APOE genotyping and confirming whether or not we can send those, the insurance reimbursement is there, and there's genetic counseling for what those results may mean for the patient and risk stratification for those patients. You want to ensure that there's an infusion center and work with their staff to ensure safe administration, access, and appropriate volume for beds. We want to make sure that we can communicate well with our emergency and urgent care providers, including primary care physicians, to be aware of treatment and signs of symptoms of amyloid-related imaging abnormalities, also known as ARIA. And finally, really thinking about the financial burden of treatment. This may not only include treatment and insurance reimbursement of the medication, but thinking about infusion reimbursements, thinking about nuclear medicine for amyloid PET or cerebrospinal fluid addressing, APOE genotyping, and multiple MRIs that are required for safety and ensuring the baseline capabilities. It may be difficult to identify broadly every site's specific burdens, but really thinking proactively with other care providers about what barriers may be and financial limitations. So first we'll start with a case. Here we have Fred, who's a 63-year-old man working as an electrician and has been working as an electrician for the past 35 years. His Montreal Cognitive Assessment was 22 out of 30, which is consistent with what we expect for someone who has mild cognitive impairment. He had cerebrospinal fluid testing, and it was consistent with underlying Alzheimer's disease pathology, which was determined by the p-tau 181 ratio over A-beta 42. And his score was 0.044, which was in the abnormal range, consistent with underlying Alzheimer's disease pathology. Given these findings, we thought he was appropriate for amyloid-targeted treatment. He also had an MRI that was consistent with atrophy pattern that we would see in Alzheimer's disease. There were no other abnormalities such as prior ischemic stroke, large macrohemorrhage, or masses. And there were 2 microhemorrhages, but no superficial siderosis on the gradient echo sequence. His APOE genotyping was 3-4, and he had no other comorbidities or medications that would be contraindicated for amyloid targeting treatment. Before we jump into administering this, it's very important to make sure we discuss with patients what the expectations are and the risks of receiving this therapy. I always discuss with my patients that these medications are not a cure. Some are very excited to get a new therapy, but we really need to temper those expectations with what the data has been showing in these clinical trials. That essentially these medications help maintain or minimize progression. We help maintain the functional independence for longer for these patients, but they do not reverse memory loss and are not reversing what was lost. So setting those expectations up front are really key. We really need to be clear about the side effects, namely ARIA, the amyloid-related imaging abnormality, and those include cerebral edema and cerebral hemorrhage. And that because of these side effects, there are frequent visits to our center or imaging facility to monitor for this with MRIs and making sure there's good communication. But if this is not appropriate for the patient, still stressing that there are alternatives to receiving the amyloid targeting therapies, such as lifestyle modifications and current symptomatic therapies that have been available and are still currently available. So for Fred, his commercial insurance through his employer denied coverage of treatment. And this is a real issue that all of us are facing. How do we manage these insurance issues? What are the potential costs associated with Medicare versus private insurance through an employer versus Affordable Care Act? And what can we do as providers to assist our patients if they are denied treatment or a prior authorization is required? Dr. Salloway, yeah.
Well, Sharon, if there's no coverage, there's no access. So the financial and billing people need to be part of this process right from the get-go and involved with each case to help navigate and make sure the patients have as much support as possible.
Exactly. And that's what we've done as well, is really ensuring that patients are aware of what they're getting into, that it's not as simple as just writing a prescription. The cost of amyloid targeting therapies for people with Medicare, we know that traditional FDA approval are covered by Medicare Part B, and that for original Medicare, 20% of coinsurance after Part B deductible is met. And Medicare with supplemental coverage or Medicare Advantage, less than 20% coinsurance. There are other potential treatment-related costs that patients should be aware of, and that having a financial counselor or advisor as part of this process will be very important. Whether the confirmatory testing for amyloid with an amyloid PET is covered in your area, and that may be regional. CMS had stated this would be covered, but it can vary in terms of when that reimbursement has been approved. CSF biomarker testing has generally been covered by Medicare, but it's currently unclear if Medicare will cover tests required for safety monitoring, such as APOE genotyping and the serial MRIs that are required for safety. Have you had any experience with this, Dr. Salloway?
Well, Medicare has said that they will cover each of these ancillary tests. And I think they are covering the MRI scans, to my knowledge. APOE is unclear to me, but they have verbally made a commitment that they will cover it.
That's helpful to know because I think it can vary by region. And so
Right.
we've had some delays personally at our site due to confirming this before moving forward. And the cost for amyloid targeting therapies for people with commercial insurance from their employer or through the Affordable Care Act. So people may ask, what is the cost for when someone has a commercial insurance? And when it's through an employer, usually at least 50% of the premium costs. Private health insurance on the marketplace may be eligible for premium tax credit subsidies and other cost-sharing reductions. And insurance coverage for amyloid targeting therapies depends on your geographic location and insurance provider. Any thoughts? Yeah.
Yeah. This is a tough one. I think this is a new process for private payers, and they're not used to an infusion therapy for Alzheimer's disease, and especially one of this cost. And so there's a variety of responses in our early experience. We may have one commercial insurer from one state that call the treatment experimental, and the same company in another state approves it. One will pay for an amyloid PET scan, and one will only pay for CSF. So these variations. So I think each site really has to work with their insurance, with the insurance companies, and try to educate them. And unfortunately, there often is a prior authorization process and a number of hurdles to overcome to obtain coverage. But it's important to do so that patients can receive the therapy.
I agree. And for us, it has been sort of trial and error with each insurance provider for those that are not Medicare to really understand the process for each patient.
And the companies can help too. So they may have some patient support services that are available both to navigate the insurance system, but also maybe provide some degree of offset so the patient doesn't have to bear the full burden.
And you're talking about the drug companies, correct?
Yeah.
Mm-hmm. So for prior authorization requests or appeals for denial of coverage to your patient's insurance plan, there may be some prior authorization. So for those requests only, really meeting the deadline for submitting these prior authorization requests to help avoid denials can be very important. And checking with the payer to find out the length of time for authorization and how long that will last. And that's key, I think. A lot of times patients are really eager to get the medication and trying to figure out how this authorization process and how quickly that can be resolved and how long it will last. For prior authorization requests and appeals for denial of coverage, we need to make sure that we include specific ICD-10 diagnostic codes where appropriate. And for our site, we had to learn and speak with multiple parties about which codes were approved for specific tests. We need to consider to include the following information: the diagnosis and indication for the medicine being requested, the clinical rationale for treatment, and why it's appropriate for your patient. So supporting documentation such as articles and others may be helpful, including the full prescribing information, the FDA approval letter, the patient's medical records, and the summary of our recommendations can be particularly helpful. Any comments from your experience, Dr. Salovey?
Yeah, they also want to know that the patient meets the clinical criteria, so what the mini-mental score or some other cognitive or functional rating score is, to document that they're early Alzheimer's disease. And then there may be more, there may be a denial and an appeal and multiple appeals that are required before the coverage is finally obtained.
So patience is key for both the provider and the patient. We've experienced this also, as I mentioned, with the ICD-10 code, determining which one is appropriate.
Right.
But also, like you said, really confirming that we do the appeal, having the right documentation like the MMSC. If a MoCA was done, the Montreal Cognitive Assessment versus the mini mental status examination, sometimes insurance companies are not as aware of that and letting them know that the diagnosis still fits,
Yeah.
et cetera.
They also want the documentation of amyloid confirmation. So
Exactly.
consider this a work in progress, that you're helping the field evolve by working with the providers so that they are up to speed and can provide rational coverage based on, with Medicare guidance.
Yeah, and I would say also I really have to give kudos to my nurse and our team that's been supporting all of this, because some of these details I don't remember, I'm not aware of, because of the experience working with finance and the drug companies to understand what codes are appropriate, what we're documenting can be very
Right.
key.
Right.
And then here, we can use an infusion center locator to help facilitate where an infusion site may be close to a patient and help facilitate probably understanding whether their insurance company would cover it at this location. Dr. Salovey, do you refer patients out, or do you have an infusion center at your site?
Well, we have an infusion center in our program with a terrific team. Thank the Lord for that. And then we've been using it primarily for research up till now, but now we're starting to use it also for clinical care. But then our healthcare system has other infusion centers that are very well established that we can take advantage of. And I think that's probably true of most healthcare systems.
For our healthcare system, we have multiple infusion centers, which is good. But the difficulty is then the limitation on beds, because we have oncology, other infusion clinical treatments. These centers often both provide clinical care and research administration. So in terms of volume, as this rises, we may start to need to think about alternatives for infusion centers beyond
Sure.
our health center.
It definitely takes planning.
So when we think about ordering these, and this is a sample, but there are benefits to ensuring that our checkboxes with the infusion set. So for our site, and you can give me your thoughts too for yours, in this sample, there's a checkbox for confirming the diagnosis, the documentation for the biomarker, whether it was CSF or amyloid PET, including weight, because these are weight-based therapies, including the cognitive assessment that was used, because that's often required for documentation. And then really key are confirming that an MRI was done. The MRI may not be required prior to every infusion, and that's true, but confirming that it's done and reviewed and having a communication pathway between the infusion center, yourself, and radiology may be very important to ensure that an MRI was reviewed and safe prior to the next treatment. Do you have something like this, Dr. Soloway?
Well, it's interesting, Sharon. What took us the longest time in getting started was creating these order sets and getting them in the electronic medical record and
Yeah.
so forth. That
Yeah.
was the most laborious piece, just working out those details. Even though we had already done it with aducanumab for lecanemab, it also took a round of startup. So that and what you just said about the coordination of care, because when you refer out, you still have to monitor for ARIA. And especially if they're not at your site, then you have to rely on the nursing team at another infusion area to communicate with you, what's going on with the patient and with radiology. So just being careful about what's going on is really important.
Exactly. I think it took us a long time with our order set as well. And it was really a good communication with our pharmacists and our infusion center, radiology, to create this large order set that's standard, but knowing that there can be variations, especially if we needed to add an extra MRI or holding therapy for a moment. And what
I'm
to do
glad
about
you
that.
mentioned that, because pharmacy is really an important part of this team.
Yeah. And they want to understand too, if there are any specific limitations or comorbidities or other medications that
Sure.
we have concerns about as they move forward. So they can be another sort of check balance
Sure.
to help facilitate. And from the outset, it's really important to make sure that we can identify an MRI facility that's close to the patient, and making sure that they have availability and the scheduling can be booked out. It's much easier to book all of the MRIs that are required up front at the time that we're prescribing, rather than having to scramble or ensure that it's done within the time frame. Similarly, I think it's important to make sure that an MRI is done with enough time prior to the next infusion. It can be very difficult to review and ensure safety with all the parties involved if the MRI is done, say, the day before an infusion is scheduled to occur. So having all of these processes will be very important, in particular, as we know that there may be extra MRIs that are done out of the planned template. From the appropriate use recommendations publication, for which Dr. Soloway was an author, we have a monitoring schedule for safety for ARIA, and again, that's amyloid-related imaging abnormality related to cerebral edema or hemorrhage. And of course, as we mentioned earlier, we need an MRI at baseline prior to initiating therapy to confirm that there aren't any other safety issues and the patient is appropriate for therapy. But there's a regular cadence to ensure safety throughout the treatment process. So in this schematic here, you see that there's an MRI prior to the 5th infusion, prior to the 7th infusion, prior to the 14th infusion, and then potentially annually if they're ongoing in therapy. But to note that if there are symptoms of ARIA, that we can get an MRI outside of this templated to ensure that there is safety and that it is appropriate to get the next infusion. Some things to note for all of us, that there are registries, national registries, to help us understand side effects and share experiences and side effects related to these monoclonal antibodies targeting amyloid. The CMS.gov registry is required for patients who have Medicare to enter the data for reimbursement. And there's also the Alzheimer's Network. Do you want to share your experience with the AlzNet registry?
Yeah, so Medicare or CMS requires that patients receiving these treatments be enrolled in a registry that they approve. they initiated the first one. That's the one you mentioned, the CMS registry, which is pretty brief and requires some of the key elements we just talked about, their amyloid confirmation, their mini-mental or some other cognitive tests, et cetera. The ALZNet is a network designed to monitor outcomes a little more carefully with more detail than will be available in the CMS registry. We encourage every clinician that uses these treatments to participate in ALZNet, and you could participate in a lower level where you give a minimum amount of information, or you can participate in a higher level where you provide scans and more detailed information to help us really track outcomes. And that is approved. The ALZNet is approved by Medicare. So if your patient's enrolled in ALZNet, Medicare will cover the drug through that. So that's accepted.
And I think it's really important to enter this data because we want to have shared experience for real world reactions.
What we want to do is build a better clinical care model for Alzheimer's disease. And certainly we can learn from stroke, where we now have a national registry, and stroke care has just been revolutionized. And we've been tracking, and each hospital carefully monitors what they do and how long it takes them to do it, and how best practices, and we want to do the same thing for Alzheimer's. Okay, so our patient, Fred, goes on treatment with an amyloid-lowering therapy, and he develops asymptomatic mild ARIA-E on a routine safety MRI. And you can see that small area of high signal on the flare sequence there in yellow is the area of ARIA. So it's really it's isolated, it's a discrete area. We inquire, he's asymptomatic. And now we have to decide what to do. So Sharon, I don't know what you think, but the appropriate use guidelines, which we'll get into in a second, recommend that it is safe to continue to treat through mild asymptomatic ARIA like this, but monitor to make sure that it's not becoming more significant. I don't know if that's your approach as well.
Yeah, and I think, it's a good guidance. So helping understand, well, we should know, are there any microhemorrhages associated with this? Because that might limit whether or not we want to continue treatment. Obviously, in this situation, he's asymptomatic. And I think having a discussion with the patient also, whether they want to continue treatment or not, because the guidelines are such that, yes, you can continue treatment. And in our patient cohort, they're often like, yes, let's keep going. But there may be some that said, oh, no, this is what we talked about. I don't want to, So I think it's important to say these are the guidelines, but for you as the individual and having that discussion about whether to move forward.
Well, that's a great point, because it underscores really the message that the risk-benefit determination is dynamic, and it changes, and it's ongoing. It's not a one-time discussion with the patient and the family. It's ongoing as the clinical circumstances change. So here, now they've changed mildly. This patient, again, is an ApoE4 heterozygote, so he has a higher risk for ARIA. He has 2 microhemorrhages at baseline, so maybe there's some underlying cerebral amyloid angiopathy. And now he's had a first episode of ARIA. So I think it's very appropriate to go back to the patient and family and describe the finding, and then discuss the options. Like you said, the guidelines are permissive of continuation, but the patient may be more conservative, or the clinician may be more conservative. And there's nothing wrong about that. If you decide as a clinician to take a more conservative approach, because let's say he was a homozygote for E4, you're worried about the risk of a more serious episode of ARIA, that's perfectly okay. And the patient will not be harmed by that.
Exactly. And it can be that you don't have to decide to discontinue treatment indefinitely. It could be that as the discussion moves forward, we could say, well, you know what?
Exactly.
Is this beginnings of something worse? Let's repeat an MRI in a month, see if there's any change or resolution or anything like that, and then decide whether to treat.
Right. Well, we definitely want to get the follow-up MRI anyway. If
Yes.
either way,
Yeah.
either way, just to make sure it's going in the right direction.
Exactly.
Okay, perfect. I agree with that. So what are the risk factors for ARIA? Now, again, the main point I want to make here, ARIA is fairly common. So what's the most important is serious ARIA, limiting serious ARIA. It only occurs, and in all programs, about 1.5% of cases have a serious episode. And that often requires hospitalization. There may be seizures, could even be fatal. We don't want those. We want to have zero if we could. I don't know if we can get to zero, but we want to limit those. And so that's why what we were just talking about is being really careful and mindful of what's going on is really important. So I think we can, now, in a clinical trial, you have a central reader. You have a radiologist who's an expert backing up, reading every scan. Here in clinical practice, we're going to have whoever we have, and you're going to have clinicians with varying levels of experience, treating physicians as well. So that's why these educational programs are so important. So we all can learn how best to manage this new therapy. So the main risk factors for ARIA are the APOE4 copy number, and the rate goes up significantly from non-carriers to heterozygotes to homozygotes. The dose of the drug, the timing of treatment, usually ARIA occurs early on in treatment, and very importantly, the presence of underlying cerebral amyloid angiopathy. Now, sometimes we can detect that on MRI quite well and avoid patients who really have significant signs of CAA. But sometimes, especially in E4 homozygotes, the MRI can appear normal, but they have significant underlying CAA. So we can't be too complacent about that. Okay, so what do you say to patients about ARIA and what symptoms can occur? So 75% of the time, ARIA is asymptomatic. We only discover it on a routine safety MRI. And it shows up primarily as edema, that's ARIA-E, or it can show up as hemorrhage, microhemorrhages, or superficial siderosis, that's called ARIA-H. But 20 to 25% of the time, there can be symptoms. They're usually mild and nonspecific, like headache, confusion, unsteadiness, and they can be hard to differentiate from underlying Alzheimer's disease. So it's not easy to tell when to get an unscheduled safety MRI scan. Sometimes, as I said, it's more serious, there's more significant edema, and they can present with seizures and focal signs, which we'll talk about in a minute. So what we need to do is, Sharon already mentioned the importance of the baseline MRI and carefully examining that. I think that's the best thing we can do to protect patients. Take a look and don't let the MRI be too old. It says a year in the guidelines, but I think that's old. You want to get it more proximal to when you're actually enrolling the patient, because things can change. You want to make sure, and it's in the appropriate use recommendations, it's in the prescribing information from the FDA, that they don't have signs of CAA. They don't have more than 4 microhemorrhages. They don't have very little to no superficial siderosis. They certainly don't have intracerebral hemorrhage or past history of intracerebral hemorrhage. They don't have severe white matter disease, etc. These things are all put them at higher risk for a more serious episode of ARIA. And then, so that's number one, making sure our job is to determine, is this patient a good candidate for therapy? It's their decision. If they are, then it's their decision, the patient and the family, to decide whether or not they want to go on it. But our role is to pre-screen and see if they're even appropriate and guide them if they're not. If they are, then we work with them to decide if it makes sense for them. And with the decisions ultimately up to them, as long as the risk benefit is in their favor. So with MRI, there are some challenges there. So we're talking about challenges and hurdles. The studies were done primarily with 3 Tesla magnets using a GRE sequence to detect hemosiderin. Some clinical scanners may be a lower magnet strength, which aren't as sensitive for detecting CAA or ARIA. So you'd like to get 3T if you can. You'd like to use the same scanner if you can from one time to the next. That may not be possible if someone has an urgent situation and needs to go to another center. We definitely need a flare sequence to look for edema. We need a heme sequence, and I think increasingly that will be susceptibility weighted imaging, which is more sensitive than GRE. Now, we picked an arbitrary cutoff of 4 microhemorrhages. We're going to see more microhemorrhages on SWI than we will on GRE. And so clinicians will have to decide if a patient has 5 microhemorrhages on SWI, is that okay? Are they a good candidate or not? And so the clinical judgment will be required. Some centers are getting both GRE and SWI and then trying to weigh this out. But increasingly, the field is going to move toward more sensitive imaging. And then it's very important, once they're on treatment, to make sure if they have a problem, you want to get diffusion weighted imaging, because the ARIA can present as a stroke mimic, and you want to make sure they're not having a stroke. So having the diffusion weighted imaging really helps.
Can I say something there?
Yeah.
When we talked about communicating with other providers from the outset, our site worked really closely with neuroradiology to create our own protocol for MRI monitoring. So we have a memory protocol that we do for, diagnosis, but for this, we don't need that full memory protocol. And we, as a center, decided to have both the GRE and SWI, and obviously not always available, but when we can, we try to have an MRI baseline at our center, because an outside scan may not have that SWI, and we're going to have that. Obviously, it's not required to be repeated, but it'd be nice. Our preference is that we have that, and like you said, as close to baseline treatment infusion as possible. That 1 year may not capture some microhemorrhage that happened just before treatment.
Well, it's great that you have that relationship with radiology. I'm really happy to hear that. And we do too. And our radiology team calls us with every ARIA case. I just want to let you know your patient has ARIA and describes it, so we can respond right away. And that's terrific. So we really want to encourage that kind of communication and that careful review. And then clinicians also need to get comfortable reading these things. Reading, the radiologist needs to develop the expertise, and then the clinician should as well. So there's more than one set of eyes looking at the scan.
Yeah, it's a shared learning experience.
Absolutely.
So if there isn't that communication, if you are sending a patient to another radiology facility, I think documenting, the sequences that we require to make sure that they're safe.
But also having communication with whatever radiology center you're working with. As best communication as you can. It's going to be in the patient's favor. Now, there are things coming. This is, near future, is there are automated, it'd be good to have an automated, a standardized read on every MRI scan for CAA and for ARIA, and to have that in the chart. And so as much as that's what we did in the clinical trials, to try to emulate that. And there are software programs based on machine learning that are coming that can give an automated read that look really sensitive. So stay tuned. I mean, they're not here yet, quite yet, but they're in the process of rolling out. And there is actually Medicare a code for covering that. So hopefully they'll get into practice before long.
Oh, exciting.
So we already mentioned about there's ARIA-E, which is associated with edema. There's ARIA-H, which is associated with hemorrhage. There is a rating scale, and that's important because we make management decisions about ARIA based on the radiologic severity. So again, this is a little bit arbitrary, but just so you know what the guidance is from FDA, if there's an isolated area of edema that's less than 5 centimeters, it's considered mild. If there are multiple areas, it's considered moderate. If there are areas that are between 5 and 10 centimeters, that's considered moderate, although you can imagine if there were many of those, that would be severe. And then if there's any area that's greater than 10 centimeters, that's considered severe. And you'll see in a second how we utilize that in clinical practice to manage ARIA. Similarly for ARIA-H, if there's less than 4, again, these are not strongly evidence-based. These are numbers that were chosen to correspond to what we think is mild, moderate, severe. Less than 4, less than or equal to 4 new microhemorrhages, that's mild, 5 to 9 new incident or microhemorrhages are moderate, and more than 10 are considered severe. And then for siderosis, which is important because siderosis is really the lining of the meninges with blood products. Usually there's underlying amyloid in there. That's a little bit more of a marker of CAA and more concerning about a more significant hemorrhage. So 1 new area of siderosis is considered mild, 2 is considered moderate, more than 2 is considered severe. And you can just see examples of that on this slide with edema and with hemorrhage. Okay, so what do you do? If someone has ARIA, we already dealt with one scenario. Our patient, Fred, had mild asymptomatic ARIA. So generally, the guidance is if the patient is asymptomatic and it's radiographically mild, dosing the clinician can choose to continue dosing with ongoing clinical and safety MRI monitoring till it resolves. If they're symptomatic, even if mild, dosing, for anything that's symptomatic, we recommend suspending dosing because it's a more significant episode, even if it's mild radiographically. If it's moderate to severe radiographically, we recommend suspending dosing and then getting MRI and clinical monitoring until it resolves, and then deciding whether or not it's safe to resume treatment. Now, Sharon brought up a good point about coincident microhemorrhages. So someone may have a moderate area of edema, and that may have no microhemorrhages or numerous microhemorrhages. And the microhemorrhages tend to occur a little bit later and add on, grow a little bit over time, especially for significant cases of edema. So you have to be prepared that there will be fluctuations or changes. And then we recommend if there's any cerebral hemorrhage, macrohemorrhage, any severe ARIA, that the dosing be permanently discontinued. Hopefully the patient will do well and get through that episode okay, but you don't want to expose them again and take the risk that they'll have a similar severe episode. There are also some other recommendations from the appropriate use recommendations for discontinuing treatment. More than 1 area of superficial siderosis, more than 10 microhemorrhages, incident microhemorrhages, more than 2 episodes of ARIA. Patients have to go on an anticoagulant. They should be discontinued. Okay, so as Sharon mentioned, it's an ongoing conversation with the patient and the family as the clinical course evolves. If someone develops ARIA, hopefully it resolves radiographically and clinically if there are any symptoms, and then you can meet with them and decide whether or not to resume treatment. Okay, so now we come with a more serious presentation, which could be ARIA or something else. A patient who's been on amyloid-lowering therapy develops confusion, headache, aphasia, and unsteadiness. And his family is really concerned, obviously, and they call and they want to know what to do. What do we do next, Sharon? This sounds serious.
Yeah. Yeah, I mean, with any symptomatic or any symptoms, I think we need to determine urgency. And so in this situation, obviously, we would want to look for ARIA. The question here is, does this patient need to go to the emergency department to get that MRI and evaluation for all of these other symptoms? Or is this something we can manage as an outpatient? And I think it really needs to be a discussion with finding out about his symptoms. With all of these symptoms, I think he needs an urgent evaluation.
I agree. So that's one of the challenges. When do you need an urgent MRI, an unscheduled MRI? That's clear here. We need an urgent MRI. When can you manage it as an outpatient? And when do they need to go to an emergency room to get evaluated? In this case, clearly is moving toward the, more higher level of care because of the prominence of the symptoms. And, with the aphasia, if they present to an emergency room with aphasia, that raises the possibility of a stroke, of a stroke-like episode. And so we have to be really careful because, as you know, there have been some devastating consequences of giving thrombolytics, which are done quite readily in the emergency room for patients with inflammatory ARIA. It's caused fatal hemorrhage. So we want to we want to limit the use of thrombolytics. So if we decide to send that person, he clearly needs an urgent MRI. We have to stop the antibody, but that's probably not going to be imminent, not going to reverse the problem. And then we have to determine what's going on and treat it appropriately.
Yeah, I mean, I think the benefit of going to the emergency department is getting evaluated immediately, getting that MRI, but making clear that it's an MRI. I think if it's an emergency department that is not affiliated with your institution, there may be an evaluation in which a CT scan is done. So it's really communicating with the local urgent care provider, in addition, patient and family, to really insist upon that MRI to determine whether this is a macrohemorrhage, or is this ARIA-E, or is there truly a stroke, or is there a seizure? You know, all of these possibilities are there, and discussion about, well, you know, the standard of care, which is great for stroke therapy, is to get a CT, you know, confirm that there isn't a bleed, and they may initiate a thrombolytic, as you said, but that's not what we want here.
Right. So the advantage of going to the ER is they can get an urgent evaluation and a higher level of care. The downside is they're at risk of being exposed to other treatments like thrombolytic therapy, which could have very negative consequences. So we have to weigh that. And I think the best thing is to plan ahead. I mean, hopefully each center won't have too many cases, but they can occur. They have occurred at our site. You got to be ready for them. And you have to have good communication with your emergency team, with the stroke team. You can't always send the patient to the hospital you want. You know, you may want them to go to your hospital where you have a good, good relationship, but they may end up going to a local hospital emergency room. So whatever happens, you have to communicate with that ER and stroke team wherever they end up going. Okay, so the ER team, the emergency team needs to know that, and this is our responsibility. If we're going to offer this treatment, we have to help educate our colleagues so they can help us in providing care in these more extreme situations. They need to know the patient's on an amyloid-lowering antibody. Hopefully, it's in the medical record. They need to know what their APOE genotype, hopefully that's in the record as well. Their underlying comorbidities, if there's underlying CAA, if they've had prior episodes of ARIA or not, where they are in the treatment with the drug. And most importantly, they need to know that ARIA, especially inflammatory ARIA, can be a stroke mimic. Present with focal signs, present with seizures, and they need to factor that in. Hopefully the stroke guidelines will be updated to include this. I know there are plans for that. It hasn't happened yet. So we have to sort of do this by word of mouth and writing about this and doing these webinars and whatever we can do to get the word out so that the hospital teams are aware and can take the appropriate steps. Now, the real challenge is the sequencing of the evaluation. Because when people come in with a focal presentation, there is a set approach to ruling out an ischemic event. And at our place and in most hospitals in the country. So they usually have a CT angiogram, and if that's negative and there's concern about a stroke, they get a thrombolytic while further testing is being done. We don't want that. So we have to work on that sequencing. And at least for us, some centers can get an MRI in the emergency room in a timely way. Others really have to wait many hours to get it. So it's much easier to get a CTA, that's become a standard, than it is to get an MRI. So that's a challenge. That's going to be a challenge across the country in managing cases like this. So we just want to we want Fred to get the most appropriate evaluation and treatment and avoid anything that could be harmful. So it looks like Fred goes to we do the outreach. We communicate with our colleagues, and he goes to the ER and he gets an MRI scan, which shows multifocal areas of edema and numerous microhemorrhages. So that is, and the diffusion image does not show, maybe it shows a tiny diffusion abnormality, but doesn't show anything significant that goes along with a major stroke. Now, there may be a tiny diffusion abnormality, so the team should not take that to mean that the primary event is ischemic if you have a large area of edema. So just FYI. So that's really good. So now we've determined that this is ARIA, and we want to help. We're going to stop, obviously, the amyloid-lowering therapy and permanently discontinue it in this case. And then the guidance is to use an empiric high-dose steroids to help reduce the edema and help with the recovery of the symptoms, and also monitor for seizures, which can occur in more inflammatory episodes like this one, and treat them if there's signs of epilepsy. Any comment, Sharon?
No, I think, in this situation, seeing his MRI, we want close monitoring. And because, as you said, there could be seizures that develop. So in this situation, we just want to make sure that no further risk comes to him. And it's tough, again, close communication with critical care, stroke colleagues, and emergency can be really beneficial in providing the best guidance here.
Well, I think in this situation, it'd probably be best to admit him at least to an inpatient unit, depending how sick he was, if he needs, intensive care, but at least to a hospital unit, and for empiric steroids and monitoring for seizures. And it's important to know that the symptoms and the MRI changes can fluctuate.
Exactly.
So they can move in one direction, and then the next MRI get worse. And the person goes home, and then
yeah.
Person goes home, and then 2 weeks later they present again with seizures. So this is a pretty dynamic process when it gets to this level. Yeah, it's important to be aware that there can be serious consequences of giving, thrombolytic treatment to patients in an episode of severe ARIA. This is a patient reported in the literature, an E4 homozygote who presented with a focal presentation, which was thought to be a stroke, received TPA, and soon after developed this, multifocal dramatic hemorrhage, which was fatal. So we want to try to avoid that. And turned out on postmortem examination had an underlying severe CAA and an arteritis, a vasculitic process.
So Fred has been on amyloid targeting therapy since August 2023, when he had a 22 out of 30 on his Montreal Cognitive Assessment. In April of 2024, his MoCA has now progressed to 17 out of 30, and his FAST score indicates that he's progressed to moderate dementia. Now, the question remains, does he continue on therapy? And this is something that is not clear. So then the question remains, at what point do we discontinue or modify treatment? Is there a maintenance therapy that is required? And what's the risk benefit as someone moves along in the disease progression, and including with both feasibility and access with finances and the burden to the patient and family to continue with therapy? So there's a lot of unknowns at this point. What are your thoughts, Dr. Salloway, with Fred's situation as he's now at this moderate stage?
Well, I think it's an important issue because the treatments are approved for early Alzheimer's, so MCI and mild dementia. The evidence so far shows that people in milder disease stages actually do best with these treatments. So they're not approved for later stages. Unfortunately, patients will progress. These medicines don't stop the disease process altogether. They may slow it down a bit. So we're going to be dealing with this, more and more. And I think it's part of that risk-benefit discussion with the patient and the family. It's just ongoing. And now the patient has become more impaired. They require more care. We're going to make sure they get the services they need and the support they need. That's really important. And it may be that the drug is less and less important, and it may be actually burdensome coming for treatment, the cost of care. Hopefully there's not too much safety monitoring at this point, but still, it's unclear if there's benefit. So I think it's a clinical judgment and an ongoing, really great relationship with the patient and family where this is discussed openly. Now, sometimes families want to hang on. It provides a sense of hope that they're still getting a special treatment that might slow things down, even though really the evidence is not there for that. And so we sometimes are patient with that for a little while, but there comes a point for most patients where it really no longer makes sense to continue treatment. And then I think there's a point for discontinuation for many patients, and it's good for clinicians to recognize when you've reached that and just be honest with the patient and the family.
Exactly. And I think that's something that we often think about when patients and families really feel connected to the provider, that they want that maintenance because not just of the drug, but potentially because of the care team and the care that's provided. And that sort of lends well to this slide, in which we think about the multidisciplinary care that can help support patients and families. For our site, we have a multidisciplinary clinic that includes a social worker from the outset prior to initiating therapy, and that can be a resource as needed throughout. And maybe that's where it can be benefited in terms of as the staging to moderate dementia, now that Fred is in that stage, may needs different types of support. The family may need different types of support, and thinking about goals of care at this point, in addition to potentially inviting palliative care colleagues to think about what are the goals of care. And as someone changes in the disease process, there may be more morbidities that accrue, including polypharmacy, and are we contributing to that when we're not sure if this is beneficial? Any comments here?
No, I think that's really important that social work and geriatric care planning are involved to support the family and help them as unfortunately, the disease progresses and the care needs change. And I totally agree, Sharon, that there's a big benefit for coming for treatment frequently. Mm-hmm. For both the patient and the family. They're part of something important. They're connected to nurses and other clinicians and technicians that are supportive and welcoming to them, and it's supportive for the family. So there's a real loss when the treatment is discontinued, not just the medicine, but the extended team that's been involved with them.
Exactly. So I think this is really just denoting that a multidisciplinary team, but transdisciplinary within across departments can be beneficial. And we've said this throughout this webinar that communication is key. So from the outset, talking to our infusion collaborators, pharmacy, neuroradiology, nuclear medicine, all of the care partners, including stroke and ER. But then as the disease advances, thinking about geriatricians or primary care doctors, psychiatrists, social workers, all of these can be really beneficial in supporting patients, and whether it's support groups and others, and thinking about managing the disease as they change.
Well, we wish everybody well, and who decides to pursue this treatment and setting up their program and addressing the hurdles. Hopefully some of what we said today has been helpful. It really takes a team approach, and the patient is a key part of that team and the family.
I think my only thoughts here are that the newness is exciting. I think we're at really an inflection point in care for Alzheimer's disease, so it's really exciting. These therapies are also exciting, but really to temper that excitement with the fact that we have to be patient, these are not a cure, so really counseling patients and families that this is really exciting, but it's not reversing the disease process.
Well, I think the big thing is just being careful, and I would feel more at ease the more we're careful in patient selection and in safety monitoring. I think if we're careful about it, we try to write these guidelines to make it super practical, so that we can do that safely.
But yeah, every patient is different, and I think that's where we take these cases, and it helps us kind of give a frame of reference. Thank you.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/NUR860. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Lilly.